So I'm really pleased to start this webinar. And it's been such a long time since we've had a webinar. I think it's the best part of a year. Um, and a very warm welcome, please, to Eike and Eliane, who are part of the psychology team in the specialist centres in England. We're very privileged to have this facility, and we're very privileged to have you both here this evening. So I'm going to hand over to you and let you lead. Thank you.
Thank you very much. Just checking that everybody can hear me okay as well. Joe, can you hear me? Can everybody hear me?
Yep, absolutely can hear you.
Great stuff. Okay, so welcome. My name is Eike, and I'm the clinical psychologist for TTP in Oxford. And I'll just let Eliane say hello as well.
Hi everyone, so my name's Eliane and I am in the Cambridge Centre.
And what we'll do is I'll give you a little bit of an overview of what we'll cover tonight. And then obviously there is the possibility to sort of ask questions and have a bit more interaction in the end as well. But what we've been asked to do and what we thought would be helpful is to talk a little bit about psychology and TTP and why it's even here and what we might do. And then we'll talk a little bit about what we might do in a bit more detail. So what a typical day might look like, the sort of stuff we might do, and the sort of things we can offer, bit of what we can't offer. And then we've also got a little bit at the end to just introduce the other specialist centres, because obviously we know you come from all over the country. Some of you might see us, some of you might not. So we thought it'd be nice if you can just get a bit of an idea of who everybody is, basically. And so you might know the background to all of this because you might have seen Joe talk about it and other people at the network talk about it. But the starting point of this was really that there are now these 9 specialist centres in England for TTP. And it's a really recent thing. And we're obviously really grateful for everybody. And we know Joe has been very heavily involved in this to start the ball rolling and actually get these centres set up. But it only started a couple of years ago in terms of the commissioning, and they were only set up sort of during last year and this year. So this is still work in progress. And every centre has a clinical psychologist attached to it. But it's not that clear from the word go what the sort of remit is. So what would be helpful, what we're supposed to do, what we're not supposed to do. So I guess that's something that we're trying to figure out together with patients so that we offer what is actually needed. This is a little quiz. Let's see. So I've tried to get a picture of every centre that is there, and I would imagine most of you know where obviously know where your own is. You might know some of the neighbouring ones. So if we start at the top left, I don't know how easy it is to make this interactive and whether people can answer, because I know Joe talked about the confidentiality. So I'll just talk you through it, and you can, for your own sense at home, see if you can guess which each of those is. So the top left, if we start there, that's Liverpool. Okay, the one underneath Liverpool is Sheffield. The one who's to the right of Sheffield is Birmingham. The one with the bridge, that's Clifton Bridge, that's Bristol. And the one at the bottom is Oxford. Okay, although Oxford and Cambridge, to be honest, it's hard to always know which is which, but that is Oxford. And then on the top right, we've got Newcastle. And then under Newcastle, we've got Leicester. Then we've got Nottingham. And then on the right, we've got Cambridge. And then at the bottom, we have London. And now the eagle-eyed amongst you will notice there's actually 10 there, not 9. And to be perfectly honest, Joe might know more about it. I'm not quite sure what happened there and why there's now 10 and there was supposed to be 9. But we're not complaining. It's quite good to have, the more the merrier, I would have thought. So it's just useful to think about the fact that this is obviously only England. but, and you know yourself, it sort of covers often quite large areas, and I know that still means you have to sort of travel quite a bit for your treatment and things, but we're obviously trying to sort of do the best we can with things like doing phone calls and video calls and things like tonight. But yeah, that's where we're based.
So thank you, Eike. Thank you for introducing those areas. I have to admit there was a couple of pictures on there that I thought could have been Cambridge. It was probably Oxford that I was looking at as well. Thank you. So I think everybody has a general sense that it's not a bad idea to have psychology in the TTP team, and a general sense that, you know, it is probably a good professional to have around. But what we really don't know yet is very much about what are the psychological consequences of having TTP, and what would be useful to provide in the TTP centres. And I think, you know, we can have a very good guess, and we can kind of respond to what's coming up. But definitely, you know, the group of psychologists that now exists are very much coming together and thinking about these questions and thinking about what would be useful. And we'd really love to hear from you all as well with regards to your thoughts to that. I think what everybody knows is that initial diagnosis, that initial treatment is pretty frightening. It's pretty full on. And we know that there could be quite a wide range of experiences at that point, with some people being very, very, very poorly when they come in, and some people kind of walking in seemingly fine. We can know some people can have lots of other difficulties that happen at that point as well. We know some people, you know, maybe aren't conscious at the very beginning. And we know that TTP is quite rare, and so outside of the specialist centres, there's not always great knowledge about TTP. So if you started your journey perhaps in a hospital outside of the specialist centre, you might have had a different journey in to other people in terms of how quickly it may or may not have been picked up. But one thing's for sure, I think across the board, it's a pretty frightening time when you're diagnosed. And then there's a little bit of research out there. We know kind of going forwards that pretty much about 2/3 of people with TTP will experience at least mild symptoms of low mood associated with the TTP. We know that about 50% of people will feel anxious. And we know about 1/3 will have signs and symptoms similar to post-traumatic stress disorder. So I think, you know, in short, if you're not presenting with psychological difficulties, particularly in those early stages, you're probably in the minority. So we know it's a really tricky time. What we're kind of also still working out is what might be some of the neurological symptoms that might come along with TTP, and we're not quite clear yet on the specifics of that, but our sense is that it can be quite wide ranging, and it can be quite common, particularly when your TTP is quite acute. So things that people kind of report to us is that they have problems with their memory, they have problems with their attention. Some people report very specific language problems. Some people report that it takes a little bit longer to process information than it did before. It's quite difficult to research this sort of thing because we don't know what you were like before you had the TTP. So we can have a look and say, well, right now, these are the things that you're finding difficult, but it's difficult to know how that's changed since before TTP. It's also difficult to have a sense of, you know, all the medications that you go on and your psychological well-being. All that will have an impact on what's going on for you with your cognition. And we also know that fatigue has a massive impact on our cognition, and as you will all have first-hand experience of the great fatigue that you can feel with TTP. So it's really quite difficult to tease out what might be going on for people with regards to their neurological symptoms of TTP. longer term, we kind of have a sense that, you know, when you're in remission, that perhaps it's less of a problem. But there's also a camp that maybe thinks there's some more subtle difficulties that still remain. And so the jury is still out with all of this, and it is something that we're very much thinking about as we go forwards. And then kind of thinking a little bit more in the longer term, living with TTP, and we're going to go on to talk about this a little bit more today, Eike and I, but we know that longer term adjustment can be really difficult, not just for the people that have been diagnosed with TTP, but for everyone that's around them. And that there's a great task, I think, in terms of what's my new normal now? How do I go forwards and live with TTP? Eike, can you click onto the next slide for me? No.
Hold on 1 second. I think that's because I changed my there we go. Is that, no, that's two.
That's it.
Yeah, there we go.
Okay. So at the moment, nationally, we have 7 psychologists in post. We have 2 vacant posts. We know that the psychologist in London is coming shortly. I'm not quite sure what their start date is, but they've been appointed. It's been a little bit more complicated in Birmingham, and I know the team there are working extremely hard to try and get their psychology post up and running. And then there's 7 of us in post nationally, and we will show you some beautiful pictures of those psychologists and tell you a little bit more about them a little bit further on in the post. So there's a psychologist in each area, which sounds brilliant, but actually all of us only work a very, very little bit of time into TTP. So for example, I think Eike at the moment works half a day, and I work 12 hours, but I also cover other conditions other than TTP and that. So there is a dedicated psychologist, but with a limited amount of time, and it'd be really useful to think with you guys about what's the best use of that time. And as we kind of talked to, we're really well connected as a network of psychologists. We very recently met in Liverpool for our first annual away day meeting. And we really enjoyed sitting around the table together and really thinking about TTP and what's needed and what our tasks are and how to drive forward in this area. So we're a very united group, really keen to share our ideas and our practice and our knowledge, and to really link that up to benefit everyone across the UK. And so if you could just keep some thoughts in your mind as we're going through, because Eike and I and the rest of the psychologists would really love to hear from you, perhaps at the end, about what would be useful from us and what you think is possible in the amount of time that we have. And we will talk, you know, today with a little bit about what our ideas are and what we're seeing and what we think too. Okay, thank you. Over to you, Eike.
Thank you very much. Okay, there we go. So I thought I'd give a little bit of an example about what I do in Oxford at the moment, bearing in mind I only started in post in May. So as I said, it's a bit of sort of work in progress, but I think, and we're trying with the National Psychology Network also to sort of streamline things so that everybody feels pretty much across the country that they're getting offered something similar. Obviously, there'll always be local variation, and that's true even for your medical care, but we're trying to sort of make it as similar as possible. So at the moment, I basically offer a review for every TTP patient who wants it, and that is a sort of psychological health check. So the idea is that it doesn't matter whether you were diagnosed this year, whether you were diagnosed 12 years ago, you know, whether you were diagnosed 25 years ago, anybody who's on our books, as it were, has got access to this. And I'm quite keen to sort of just see how people are doing. And that means screening or checking for sort of more specific mental health conditions. So things like the things Eliane mentioned, anxiety, low mood or depression, post-traumatic stress or cognitive problems. But to be honest, I'm also quite keen to hear how people are managing well, and how they're coping, and what they found helps them, and how they're just sort of, you know, managing their day to day, but also managing that sort of uncertainty that comes with having TTP. And because that's really helpful, and I sort of feel like it's useful to share that with other people and with other patients. And, you know, I've come across quite a lot of stories of incredible resilience where people are managing incredibly well despite having had really difficult situations. But obviously, everybody at times really worries about this. And so it's helpful then to sort of figure out what works, and to see whether that could help other people in a similar situation. Because I think it is completely normal to feel really stressed and worried after having the diagnosis. But the question is how much those worries control you, and how much you can control those worries. And I guess that's sort of one of the distinctions we can make. And if you feel like actually you're not managing those worries and they are controlling you, then that's something we can probably help with and think about some ways of managing that better. And with post-traumatic stress, we know that a lot of people suffer that when they've had TTP. And I know for some people that might feel a bit strange, because it's often the sort of thing that people talk about more in the context of having been in a war, or people who, you know, soldiers, I guess, often, or veterans often suffer from it, and things like that. But there are certain things about TTP that sort of can make it more likely that you get PTSD. And there are things like it being so out of the blue, and it being such a scary and life-threatening event, and also you feeling like you have very little control over what's happening. And sometimes people then get sort of nightmares about the hospital experience, or the time after TTP, and they get flashbacks, are the sort of things where you almost feel like you're back where that was at the time. So you're sort of not asleep, but in your day-to-day, suddenly something reminds you or triggers you, and that can be noises or things like that, and you suddenly feel like you're back there. And that can be scary, and that can definitely be made better. You know, treatment is definitely available for that. And the other thing is that sometimes people obviously feel quite low as a result of all of this, because it's a lot to deal with. And sometimes when it gets really, when you feel like you're in a really deep hole, you might not know how to get yourself out of that. And the tricky thing as well is that I know often when people are feeling like that, that's not the point where they're maybe asking for help, because it almost, that's too much already. That's too much of a big step. But there's certainly that sort of part of the reviews and things to sort of help people think about what would they do if that happened, and to also think about ways of avoiding getting there in the first place. And then the other thing that you will all know very well, and that Eliane mentioned already, is that sort of living with a new normal and what that means. And knowing on some level that TTP could come back, but living with that sort of worry and keeping that in check and managing that. And so that's another thing that we can talk about and think about ways of sort of addressing that. And so in addition to, because I only do half a day a week at the moment, it's a bit tricky, but the good news is that actually I've just been given lots more time, another day a week, which is quite a lot. So I'll have a day and a half in future. And so that's quite exciting. And it means that I can do some other things. And some of the things that I'd really like to be able to do is to attend the regular clinics that you attend with your consultants and the nurse, because I found that really helpful. And I think the patients who've experienced that in Oxford so far have found that helpful, that everybody's there all together. And if there are things that you're particularly concerned about, we can talk about it from different viewpoints and sort of try and find a solution. And also, it's a bit less scary once you've met people, to sort of think, oh yeah, maybe it is worth maybe having a chat with me, rather than just doing that with a faceless, nameless person you've never met. And then the other thing is the new diagnosis. I know a lot of you who've answered the question about what would be helpful have said, actually, now I'm fine. But at the time when this first all happened, it was very difficult and chaotic and scary. And so the plan is also to be able to see, hopefully, everyone who is newly diagnosed whilst they're still in hospital. I know that's a really overwhelming time, and it's not necessarily to do anything specific, but to just say, we're here and we will stay being here, and we will stay in touch with you so that you know the help is available when you can get your head around that, and when it's wanted. Then the other thing is families. I mean, I know that anything like this obviously has a huge impact on your loved ones around you, and on how you feel about your loved ones and how much you want to share with them or not, because I know a lot of people don't want to worry their families, but of course their families are worried. And very often, as a family member, seeing your loved one go through something that scary is very, very difficult. So I would like to be able to offer a little bit of support to family members as well. And we're thinking about sort of establishing some support groups, but also maybe one-to-one support. And, as I said, it's sort of in its infancy. The other thing is people who are having a relapse. And if you have to come back into hospital to have rituximab, how scary that is and how that feels. And so to be able to offer a little bit of support around that might be really helpful. And as a sort of psychology network, we're trying to liaise with the nurses who are doing the rituximab with you, because we know they're spending a lot of time with you. But the idea is also for us to sort of be able to offer a bit of additional support. And then lastly, there is some linking up with other services to do, because, for example, if you have TTP in pregnancy, then there are lots of services now that look at sort of perinatal health. So that's the sort of mental health around your pregnancy. But at the moment, they're not very well linked up with things like TTP. And so my aim would be to try and link up some of those services so that you get support from very early on from the sort of relevant people that need to be involved beyond your TTP team. So a bit of more joined up working. And then the last thing is more research and a little bit more development, and thinking about what do we need to know about all of this and what would be helpful, so that it feels like in future we can deliver sort of more direct care and better care, because it's based on what is actually needed.
Thank you, Eike. And I think much of what Eike spoke to is what people are thinking about, what the psychologists are thinking about across the UK. And just to give a little bit of example of how we've organised ourselves in Cambridge. So although I only do a small amount of time into TTP, I'm in the hospital all week long, which means that when we know there's been a person come in newly diagnosed with TTP, it's fairly easy for me to just go and step onto the ward and say hi. And as Eike said, that might range from just saying, hi, I'm the psychologist in the team, nice to meet you, this is my face, to sitting down, and really thinking with the person about where they're at and what they've been through. And that would really be very dependent on the person at the time. But I very much take quite an active outreach approach. So I do like to step on and see the person, meet the family, see how everyone's doing, see how everybody's coping, see what the issues are. And another time when I like to do that is when someone has gone into a relapse. And so they would come into the hospital, and then I would maybe just step onto our haematology day units, say hi, or see them when they come into clinic, And then other kind of key transitional points, I'll be keeping an eye and an ear out. So whether it's someone, as I kind of spoke to, who is thinking about becoming pregnant or has become pregnant, or as people move into the area and are new to our team. We've had a few people recently that had been lost to follow up who are now re-engaging with. That's kind of what I mean by those key transitional points. I would actively outreach, actively make sure that I'm introducing myself, having a conversation and starting those relationships. Throughout all those points, talking very actively with our consultant haematologist, Dr. Thomas, and our nurses, having lots of conversations about how our people are doing, what they're going through, what we need to be thinking about, and very, very, very much working as a team, working together. That's kind of me actively outreaching, and then I'm kind of there in the background as needed. So when anybody needs anything related to their TTP, I'd be very happy to see people. So Dr. Thomas, the consultant haematologist, and I have set up a clinic where we're sat in rooms next to each other. And as people come through, we're very much working in a very fluid way. So Dr. Thomas might pull me into his room and I might pull him into my room, or people might see one and then see the other. And very much working in as joined up and as collaboratively as we can be, thinking about what the needs are and how we're meeting those for the people that are coming through our system. So we're constantly talking about how we're doing and what we're doing and how you're doing and what we need to do for you. And a large part of that is making sure that, you know, the psychological impact of TTP is very much being thought about. Will you flick on for me, Eike? Okay. So we appreciate that it might feel a little bit daunting if someone says to you, would you like to see our clinical psychologist? It might be like, oh, what are they saying that to me for? Why would I want to see a psychologist? And I think we do recognise that there are some myths, inaccurate stories out there about what psychologists actually do and what it might mean or look like if you were given the opportunity to see one. And so we just thought we'd spend a little bit of time debunking some of those myths and talking to you a little bit about what it's like when you come and see a psychologist. So we would start by introducing ourselves, explaining a little bit about ourselves, a little bit about our role, about why we were meeting. And I think we would all be quite keen in that early stage of meeting to kind of ease people into it, help people to feel relaxed, help you to relax, help you to land, and feel more comfortable in the room with us. We like to talk about confidentiality. We like to talk about what the limits to that might be. And I think it's particularly important as a psychologist working in an MDT, because if there's anything that you want to talk to us about that you don't want other people to know about, then we need to know to be able to keep that private. So we're quite an inquisitive lot. We're very curious. We'll be asking you lots of questions. We really want to kind of get to know you and really find out from you what your experience has been like. So we're quite good at asking questions and getting people to talk. And often people will kind of say, oh, I didn't think I had anything to say and I've just spoken for a whole hour, or you know, something along those lines. And we probably won't just be asking you about your TTP. We find it useful to get a really good picture of your whole life because you're a whole person. You'll probably find us doing a lot of what we call active listening, and in that you'll probably hear us summarising a lot what we think we've heard from you, and that's because we want to make sure that we're really understanding what you're telling us. You'll probably hear us reflecting back what we think we've heard to check that out with you. And then you might see us starting to make some links, starting to join up what we're hearing to help you make sense of your experiences, of your feelings, of your thoughts. And we like to do something called formulation, which is where we bring psychological models, psychological theories link that up with what you're telling us to try and help make sense of what's going on for you, and kind of help give you a coherent understanding of what life is like for you, what you're telling us at the time. So we will also need to talk about some of the difficult stuff. So the session with a psychologist may occasionally feel a little bit challenging, a little bit difficult, but hopefully you'll find that we're able to do that in a gentle way, and in a way that helps you move forward, rather than any other way. And I think lastly, just to say, we're the TTP psychologists, so we also come to the consultation with you with our knowledge and expertise and experience of TTP. We have a good understanding of what will have happened as you would have gone through your initial diagnosis, your initial index events. We have a good understanding of relapses and the procedures and protocols around that. We have a good understanding of what it's like to live with TTP, and lots of experience of talking with people about that. We'll bring all of that into the consultation with us.
Thank you very much, Eliane. So I thought just to add a little bit to that, because that's been quite comprehensive already, but just to sort of add as a assessment appointment, so when you first sort of get referred, or refer yourself, you know, I often do things by telemeds, by phone or video call. I know your consultants do that too, just because you are often so far away and it's just easier for everybody. It does take a long time, so it can take up to an hour, that initial sort of discussion, and a lot of it is going through some of the background so that I learn about what your particular experience of TTP was like, how it's affected you in your own view in terms of your mood, your memory, but also your work, your family, your social life, and all those sort of things. And then we might do some quick tests in terms of your mood and things like that to sort of see where you're at, to get a bit of an understanding of your point at that time. And we might discuss what you want to get out of it, really, and what would be helpful. And if it's not always, we don't necessarily use particular specific models of working. CBT or cognitive behavior therapy is something you might have heard about, because it's used quite a lot also in other mental health services. We don't always use that because it's often very structured, and sometimes with TTP, it's not that useful to be that structured. It's more useful to actually have a more in-depth, what might almost feel like a chat, but sometimes it can be useful. And if it is useful and structured, then it might really go through quite a sort of structured agenda and checking in how the last sort of week or fortnight or a time has been since you've had your assessment or since you've had a therapy session before. And then you might identify some specific issues and you might discuss those and then discuss strategies of seeing them differently. So it can feel like a really structured sort of drilling down into some specific problems you're having. But as I said, that might not be what it's like. That's one way of working. And depending on what you might need or not need at that point, that might be what we do. But it might also be that actually a discussion is much more of a rounded sort of idea around, let's just have a think about everything that's going on in your life and what that's even like. And like Eliane said, reflecting on it and just being able to be open and honest with someone who is not your family, who's not going to be impacted in the same way. That in itself can be helpful. But I know that Seda was asking me about a few strategies as well. So I didn't want to not talk about strategies. And there are, I know we can probably share the presentation with you as well in the end, which is why I've listed a few things that I'm not going to go down through in detail. But I've also got a few book recommendations at the end and some interspersed here, just to give you a bit of an idea that there are quite a lot of strategies that can help. And some of them sound very simple, but when they're practiced regularly, they can be extremely effective, because with things like anxiety and worry, when your head just spirals out of control, your body also is at a sort of constant state of alert. And one of the things that really helps you with your mind is to calm down your body. And you might have all experienced that when you take a deep breath in a situation, when you just sort of take a minute to take yourself out of a really scary situation, and you manage to take a few deep breaths, and then things just feel a little bit easier. When you practice that regularly, and you do breathing exercises, or you do specific exercises to relax your muscles, that can really help to keep on top of anxiety. And one of my top tips that people often laugh about, but it is very effective, is using blowing bubbles. So actual, like, hits bubbles and blowing them. Because when you get very anxious, you often sort of what people call hyperventilating. You breathe in a lot because you feel like you can't get any air, and you're not breathing out enough. And if you do some blowing bubbles, you have to do a lot of breathing out, and it can be fun to pop them, etc. It just takes your mind off things for a minute. So that is one of my top tips for if you get very anxious. And there are lots of other things. I know I don't have the time to sort of go through them in detail, but I just thought I'd list them just so that if you do feel like any of this is relevant to you, you can then contact your psychologist in your center and say, actually, I do feel a bit anxious, or I feel a bit low, and I need some strategies for that, or I would like to talk about it, and see what you can come up with. So similarly, as I said, that's why I'm not going to go through these in detail, because I know we won't have the time to do that, because we want to show you some of the other members in your different teams as well. But just, I guess the message from this is that there are lots of things that can be done. Sorry. There we go. I'll turn that over to you, Eliane.
Thank you, Eike. So I wanted to talk a little bit about life after TTP, because I think everyone understands the emotional impact of the diagnosis and the initial treatment and the initial being unwell. But then there comes a time for most people with TTP where your TTP is in remission, and theoretically you're well again. Some people are left feeling, well, I'm well now, but why do I feel so strange? And I think if we think about the enormous, shocking, life-changing, life-threatening experience you've been through, it can often leave you feeling very different to who you were before that initial event. And it can often leave you thinking about the really big existential questions in life. So, who am I, and what do I want from life, and what's important to me? And, you know, questions that can make you feel really, really unsettled. So some people might feel, why does it feel like everything has changed? I look at life so differently now. How could this have happened to me? Some people can describe feeling really different and disconnected from others, or that there's a sense that no one else can really understand what you've been through, or what it's now like to live with TTP. And a lot of people talk about, how do I live with the uncertainty about the future? Will this happen again? Will they catch it in time if it does? What if my bloods change quickly? What if the results are wrong? Can I go through that again? So we just really wanted to highlight that, and to say that if you are feeling any of those things, that you're not alone in feeling those things, and to very much encourage you to go and talk to the psychologist in your team and work through some of those bits should you need to. And we wanted to not forget the impact of all of this on our loved ones, on our family, and on our friends. And they've been on this roller coaster ride too. Many may have witnessed the initial diagnosis, the initial hospital treatment, and the subsequent events they may have seen the panic on professionals' faces at that time. They may have had really acute experiences of you being in accident emergency department, of you being on intensive care, you being hooked up to machines, people rushing around, seeing you so unwell. And I expect, watching that all unfurl in front of them, they would have probably have felt helpless, powerless, fearful, frightened. And like you all, probably also have feelings of anxiety and uncertainty about the future. Will that happen again? Can we go through that again? Can I go through that again? We might see that they become quite watchful and hypervigilant as a result. Is that a new bruise? Are they more tired than usual? Sometimes they can have very different coping strategies to us, very different coping styles. Sometimes that can be hard to live with. Sometimes they might be trying to protect you or pretending everything's all right, and they're not worrying about that. And vice versa, you might be trying to protect them, thinking that, helping them to think that everything's all right. So we just wanted to make sure that we're also thinking about all the really important people that are around you, and to say to you all that we don't forget you either. It's difficult. It can be very difficult for everyone.
And then just to sort of end this bit on a somewhat light-hearted note, but it's still important because of those misperceptions people have about psychology sometimes. So we can't mind read, much as people at parties often think that I can. And we won't put you on a couch, despite all the sort of comics that there are about psychologists. And as I said, normally, you know, we would see you by telemed, but obviously when we can in clinic, we also see you in person. And the last thing, we can't take your TTP away, much as we would all like to. And then just as a final thing, I'll whiz through this a bit because I'm conscious of the time and I know we wanted to have some time for questions. So I'll just flash up, and hopefully, as I said, you'll get the slides as well. So I get a bit more information about each person, but I'll just whiz through them so that you see some of the people in case you haven't met them yet. So first off is Johnny, who's Dr. Johnny Latham. He's the clinical psychologist in Liverpool. And so they cover Liverpool, North Wales, Manchester, Lancashire, so quite far reaching. And at the moment, he's also helping out a little bit with the Birmingham team, with some people who obviously can't access the support in Liverpool. And this is Anna. She's Dr. Anna Chaddock. She's the one who works out of Newcastle. And again, Newcastle covers a really big area from the border with Scotland all the way down into North Yorkshire. So again, they offer appointments in person, but also by video, phone, etc. And I think flexibility is something that is true for, you know, for all of the psychologists. We try and be as flexible as we can. Shall I just whiz through these, Eliane, or do you? Yeah. So this is Sarah Crozier. She is in Nottingham, and Sarah is on mat leave at the moment. So they haven't recruited anybody for her cover yet. So she's hoping that they will, but at the moment there is a sort of break for the psychology service, and she's returning in September next year. But the hope is that maybe there will be someone in the meantime sort of supporting that. And then this is Teresa, Dr. Teresa Wynne, who works out of Sheffield. And again offers you know, the similar sort of approach as everybody else in the other services. Yeah, if you get the chance, have a look at sort of a bit of the blurb that gives you a bit more information. This is Kirsty, Dr. Kirsty Reinings, who works out of Bristol. And again, you know, supports people with TTP since March, and sees people in person and by telephone or online. So that's who you'd see in Bristol. And then sadly, Dr. Antoinette Morgan, she's had a bit of a sort of, she has to have an operation to her wrist, so she's not been able to send me the details because she's off at the moment, but she will be back soon. So if you're in Leicester, that's who you would see in Leicester. And then obviously you'd see Eliane in Cambridge and me in Oxford. And that is a bit of a whistle stop tour summary. So I suppose we've got a few minutes to discuss some questions and have a bit of a discussion.